Tommy John surgery by Addie Zebart. Tommy John was the first person to have UCL reconstructive surgery. The surgery was performed in 1974 by orthopedic surgeon Frank Jobe. The procedure ended successfully, and after 18 months of recovery time, Tommy John was able to return to pitching in the majors. Some symptoms one may experience if a UCL injury is present are pain on the inside of the elbow, feelings of looseness or instability, tingling or numbness in the pinky finger and ring finger, and decreased ability to throw a baseball or other objects. UCL injuries are usually hard to diagnose, but some tests that may be run to determine the injury are X-rays, MRIs, or an MRI after a gadolinium dye has been injected into the elbow. The newest, most common UCL reconstructive method is the docking method. This is because it allows for robust graft tensioning, avoids the ulnar nerve, minimizes injury to the flexor pronator mass, reduces the amount of bone removed from medial epicondyle, and when followed correctly, 90% of patients return to a pre-injury level of activity. The equipment you will need to do this procedure is a loop stainless steel wire on a curved needle, number 0 Vicryl suture, surgical drill with 4.5, 3.5, and 1.5 millimeter drills, a tendon stripper, and number 2 Ethibond. The docking technique is done under general anesthesia with sedation. Once the patient is fully under sedation, they should be placed in the supine position, and a non-sterile tourniquet should be placed high on the arm being operated on. An arthroscopy may be performed before the procedure begins. The arm is placed in an arm holder, and the doctor then makes a small incision and inserts a camera on a fiber optic tube into the incision. This is a minimally invasive technique used to help the doctor view the joint and can help relieve problems that may damage the cartilage surfaces and other soft tissue around the joint. The palmaris longus is the preferred graft for this procedure. However, the gracilis autograft or the other allograft tendons may be used. To harvest the palmaris longus, a 1 cm incision is made centered over the tendon at the proximal volar wrist crease. The graft is extracted. After it is harvested, a crash cow stitch is placed on the distal end of the tendon using number 1 Ethibond suture. The proximal end is left free. The tendon is then placed in a saline solution and the wrist wound is closed. An 8 cm incision is made just anterior to the center of the medial epicondyle. The incision will extend from the medial intermuscular septum to approximately 2 cm distal to the subline tubercle nerve. The incision should not cross the path of the ulnar nerve in any way. The fascia of the common flexor pronator mass is incised in line with the UCL, and the anterior band of the UCL is incised in line with the fibers down to the level of the joint. The native ligament is tagged with number 2 Vicryl sutures for later repair. Attention is now turned to the UCL insertion site on the subline tubercle. The bone is exposed 5 mm anterior and posterior to the apex of the subline tubercle. Next, 2 3.5 mm converging tunnels are drilled on either side of the tubercle. To confirm the tunnels converge, a curved curette is inserted into one tunnel and visualized through the other. Then, a looped stainless steel wire on a curved needle is looped past one tunnel to the other and is tagged for later graft passage. A 4.5 mm drill is used to create a socket 15 mm deep in the center of the humeral footprint of the UCL. Extreme care is taken during this step to protect the ulnar nerve and prevent penetration of the far cortex. Two 1.5 mm sockets that converge with the 4.5 mm socket are drilled just anterior to the medial intermuscular septum. Suture is passed on the curved needle through one 1.5 mm socket to the 4.5 mm socket, and then repeated for the second 1.5 mm socket. The looped end must remain on the side of the 4.5 mm socket, whilst the free ends are retrieved through the 1.5 mm sockets. Native UCL and capsule are closed with the elbow in 30 degrees of flexion and a slight first load is applied. A loop suture is then used to pass the palmaris graft through the ulnar tunnel. The distal end is passed into the 4.5 mm socket and the graft suture is received through the 1.5 mm anterior socket. The graft docks when it encounters the 1.5 mm socket. Tension is applied and maintained on the sutures exiting the anterior 1.5 mm socket. The other limb of the graft is tensioned toward the 4.5 mm socket. Another crash cow stitch is made with number 1 Ethibond suture around the graft. Suture is pulled through the entry point and travels towards the free end of the graft for 1 cm. The excess graft is then cut and the suture is passed to the 4.5 mm socket exiting the second 4.5 mm socket. Both sutures are then tensioned to ensure the graft is stretched across the joint. Both ends of the suture are then secured tightly into the 4.5 mm socket. Before the incision is closed, cycle the graft. This is done by repeatedly flexing and extending the elbow while keeping tension on the suture. Replace the elbow at 30 degrees of flexion in a supinated position. Sutures are tied over the bone bridge and the knot is buried under the fascia of the common flexor mass. Tourniquet is released and the blood returns to the arm. The wound is then closed in layers and the elbow should be splinted at approximately 75 degrees of flexion.